I'm so pleased, and we hope that a lot of seniors are watching, because we'll watch this because it's on all month. A lot of them have told me that they got a lot of information with regard to different situations that they're in, and that's what we're here for. So we're going to stand for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Now if we could have a moment of silence, please. Moment of silence for our veterans, our first responders, and just have a quiet moment for them. Okay. I'd like to introduce our members. Francis McVetti.
Daryl Lindholm, Secretary.
Jenny Minton.
Rosemary Panio.
Deborah Marks.
Serafina Mastro.
Councilman Ed Lachterman.
Norino Driscoll.
Joe Falcone, Recreation Commission Liaison.
Okay, thank you very much. Today we're going to have, our first speaker is going to be our supervisor. He has a lot of appointments, so we got him on first. Tom Diana.
Thank you, Rosemary and Board. Greatly appreciate it. Greatly appreciate the opportunity to speak before you this afternoon. Unfortunately, I'm a little bit harried. I can't stay as long as I'd like to. But we got a lot of stuff going on, and you got a good board here that you can bounce all your issues and suggestions off of. Please feel free anytime that you need to give my office a call, set up an appointment, come in and see me. I had a nice discussion with one of the ladies in the back, and we're gonna have a further discussion on some accessibility issues, and that is a definite topic. We're actually at this point working on a new streetscape out on Downing and Commerce Street, to where that topic is going to be taken into consideration, because as we all know, the wheelchairs have gotten wider, the motorized wheelchairs. There has to be accessibility for the blind and so on. We actually have just completed, or it's nearing completion, the new access point out front. And if you notice, the ramp coming in has those pavers, so to speak, but they got dimples on the top. Those are to not only for non-skid, but they're to indicate when a sight-impaired or blind individual is coming up on a ramp. That's how they know when they're starting to gradually go uphill, because most of the time, if they have a guide dog or if they have an assistant, they'll say step, but that's not a step. And if you ever walked on at night, you walk up a ramp and you go, oh, geez, I just I didn't realize it was an incline. That's what those particular dimpled pavers or dimpled pieces of plastic that they put in the ground are for. So we made sure that we had them. We have our handicap accessible ramp out here that can be used in case we have to close that, and that was done during our construction here for our tank removal. But that was done. It's according to ADA, the American Disabilities Act, but we all know, and thank you, ma'am, for advising me, the wheelchairs are getting wider. Mm-hmm. And sometimes, even though it works for what the ADA says, you have to go a little bit above and beyond to try and make it better for our folks that have a little bit of mobility issue. So, look, I'm not going to hold up your meeting, and I greatly appreciate you putting me on real quick. We got a lot of great people up here, and they're gonna serve you well. Karen, it's good to see you again. We have a meeting at some point.
We're doing it.
Okay. And you got my deputy, Ed Lachterman, down there. Okay. Come on, wave, Ed. All right. Just in case you don't know who he is, all right?
I think we know most of the people here.
He is notorious. We all know him.
Oh, I thought you said Notorious Noreen. No, that's not Noreen O'Driscoll. And Joe Falcone. They're the ones that they're the glue that holds this stuff together with this board, so that you guys can have a great a great time at the senior center or the bus trips. And I went on one with Jimmy. Where's Jim? Jimmy back there. I went on one to the with the steamboat and the coal train, powered train, steam powered train. I had a ball. I said, I'm joining. I said, that's it. I want to go. He calls me now and then. Sometimes I can make it, sometimes I can't. But anyway, I'm not going to take any
Thank you
more of
very
your time.
much,
Thank
Mr.
you, folks.
Supervisor. Thank you.
Have a great day.
Thank you. Okay, where's Maureen?
You mean Wendy? Wendy.
Oh, I'm sorry, Wendy. Wendy, come up and introduce our people.
Hey, everyone.
Hey, Wendy.
Glad to see the chamber.
Wendy McNamara.
Hey, lovely to see everyone. I look forward to this meeting every month. I'm Wendy McNamara, Coordinator of Community Affairs for New York Presbyterian Hudson Valley Hospital, and it's my pleasure to welcome my colleagues today to speak to you. I would now like to introduce Dan Wall, Director of Radiology and Interventional Cardiology, New York Presbyterian Hudson Valley Hospital.
Good afternoon, everyone. Thank you, Wendy. As she said, my name is Daniel Wald. I'm the Director of Radiology and Interventional Cardiology at New York Presbyterian Hudson Valley Hospital. When you hear interventional cardiology, think the cath lab, a brand new cath lab that opened last April. So I have the esteemed pleasure to introduce my colleague and my friend, Dr. Vlad Shenzan. Vlad is a board-certified radiologist that specializes in vascular and interventional radiology. He is an associate professor of radiology at Columbia University Irving Medical Center and an assistant attending radiologist for New York Presbyterian Hospital. He is an active practicing clinician. Dr. Shenzan regularly cares for many very complicated oncology, transplant, hemodialysis, and pediatric patients using minimally invasive image-guided procedures. Dr. Shenzan performs interventional radiology procedures at New York Presbyterian Hudson Valley Hospital, New York Presbyterian Morgan Stanley Children's Hospital in Manhattan, New York Presbyterian Lawrence Hospital, now called Westchester Hospital in Bronxville, and New York Presbyterian Columbia Radiology's 2 outpatient facilities, both in Midtown and in Tarrytown. Dr. Shenzan received his medical degree from Mount Sinai School of Medicine and completed his residency in diagnostic radiology at the University of Medicine and Dentistry in New Jersey and New Jersey's medical school. He completed his fellowship in vascular and interventional radiology at Mount Sinai Hospital and Mount Sinai School of Medicine. Dr. Shenzan is actively involved in teaching of radiology residents and interventional radiology fellows at Columbia University Irving Medical Center. He is an American Board of Radiology Examiner and a member of the Society of Interventional Radiology and Healthcare Industry Association at Columbia Business School. It's my pleasure to introduce Dr. Shenzan.
Rosemary.
Hi, folks. Thanks for welcoming us here today, and thank you, Dan, for excellent introduction. I appreciate it. I'm just going to fire up my presentation. We had a PowerPoint, but the technology gremlins intervened, and so it's going to be a it's going to be a talk, but hopefully it will not be too boring. So I am going to talk to you about what interventional radiology is, what we have to offer to you and to the rest of the community, and I'll be happy to answer some questions at the end. There we go. So, as Daniel mentioned, Columbia Interventional Radiology is now at Hudson Valley, New York Presbyterian Hospital, and people don't know much about the specialty. It's sort of a black box. But it's it's an integral specialty to advance the minimally invasive techniques and minimally invasive services. And so, in many cases, people who needed our services used to have to go to Columbia. It's a pretty long schlep. And now we have, all of the services, all of the equipment, all of the technology available here. And so we are happy to provide the same service that provide Columbia to the community in Hudson Valley. And so we're a group of 14 physicians, and we provide these minimally invasive services. So what is our specialty? It's a radiology specialty, but in reality, it's a minimally invasive image-guided procedure specialty, and in many ways it's a subspecialty of surgery, but much less invasive. We use often blood vessels to negotiate through the body to get to the areas of interest that we are planning to treat. From a teeny tiny pinhole in the skin, and it's usually a vessel either in the groin or in the neck or even in the radial artery where you feel the pulse in the left arm. We use modalities, imaging modalities to get us into position inside the either CT scanner or MRI machine or fluoroscopy machine, which is a live X-ray machine. And procedures that we perform are thrombectomy, getting rid of the clots, angioplasties, opening up the vessels, embolization, closing the vessels, or tumor ablation, cooking the vessels, or cooking the tumors, so to speak. I'm cognizant in trying to use the language that everybody understands, so forgive my crudeness. And again, we have, I do have a bunch of images, but we're not going to go through those. So, there are many procedures that we do. I'm not obviously able to tell you about all of them, but I'll highlight a few which may be relevant. In a population of certain age, things start to happen to the bones. And we know that, many people develop osteoporosis with time, inadequate drinking of milk, inadequate exposure to sunlight, and so the bones become brittle. And our spinal bones are particularly vulnerable to that, to fractures. And so many people will either have spinal fractures, which are very painful, and end up on a bed rest, or end up having an external fixation, or many people will tolerate those over time, and they'll just kind of get up after a couple of months and resume their normal activities, but they'll lose their height, or they will become a little bit kyphotic. In other words, the spine alignment will change. So we have techniques to fix that, especially in an acute phase. Let's say someone slipped on ice and they have this pinpoint back pain, and turns out that they have a spinal fracture. It used to be that there was not much to offer for this, but these days we can actually get into the vertebral body, which is the body has multiple vertebral bodies, which is the spine is made of those. And if we know that that's a vertebral body that is fractured, then it's easy to find out which one is fractured. You can do the MRI, and it will be clear as a daylight. But what's causing the pain is the migration of the fragments. So one fragment is rubbing up against another, and it's causing excruciating pain. They eventually will heal. It takes a little bit of time, 8 weeks, but in many cases the vertebral body will collapse. So it will narrow, and people lose body height, or the vertebral column becomes kyphotic. It becomes sort of like a C-shaped. So we have the ability now to fix that. In other words, we would get with a probe, with a metal needle, sort of into the vertebral body, and inflate a balloon. It's a high-pressure balloon. It's not a birthday balloon. It's not a Chinese balloon, but it's a high-pressure balloon that will, and it's like a jack. It will stretch the ends of that bone of the vertebral body, will restore its height, and then we'll deflate the balloon and fill the empty space with cement. So not only is the cement stabilizes the fragments, prevents them from moving up against another, but it also restores the height of the vertebral body. So the procedure is called kyphoplasty, and it's an outpatient procedure done the same day.
Wow.
In Hudson Valley. And, we have a great success with those procedures. So that may be something that you might find useful. Unfortunately, cancer is a everyday disease these days. And I was looking at statistics, and I think 1 in 2 people throughout their lifespan will be affected with some sort of a cancer. And we have answers to many, not all the cancers, but we have answers to many. For example, the cancers that are affecting the liver. And what will affect the liver? Many people, now we have cure for hepatitis C, thank God, but, up until a couple of years ago, there was no cure. And so those people would go on to develop cirrhosis, and they would go on to develop something called HCC, or hepatoma, or it's a primary liver tumor. There are other tumors in the liver which are primary. Cholangiocarcinoma, it's a biliary ductal tumor. There are metastases to the liver. one of the common cancers is a colon cancer, as we know, and the first place where the colon cancer will metastasize is the liver. And the reason for it is the veins that drain the colon. The first stop is the liver, because the body absorbs the fluid and liquids and solids, and all that goes into the portal vein or branches of the portal vein, and some of the stuff is not so healthy. So liver is a big detoxification machine. For example, somebody drinks alcohol, that liver, that alcohol gets into the liver, gets detoxified to the point where it's not poisonous anymore. So the point is, the first stop is the liver. This is why GI, gastrointestinal cancers, will metastasize to the liver. Now, the treatments for that, if there are metastases, and that would be a stage 4, obviously, it's an incurable disease, but we're able to give people more years of life, sort of, using a crude analogy, kicking the can down the road. But it's much better. And if you think about it, what the options that a person with liver metastasis would have, is a systemic chemotherapy, makes you extremely miserable. It's a radiation therapy, not very good for for multiple metastases. If there is one metastatic lesion, those patients go on to have it resected because there is a 20% chance of cure. But if there are multiple metastases, it's really limited to systemic therapy until recently. Now there are developments where interventional radiology can actually treat the liver metastasis, very, very successfully. And so the algorithm, we work very closely with medical oncologists, and there are wonderful, very talented people in Hudson Valley that we work with, and we do procedures with them on a daily basis. But the strategy is, you treat these liver metastases from the colon or from the breast cancer or from other modalities with high-dose chemotherapy. You debulk and get rid of as much tumor as possible. But we all know that chemotherapy is a pretty toxic modality, and you can't give it for a very long period of time and just have a good quality of life. So once it is debulked, once the majority of the tumor is gone, the small little metastases are kept at bay by interventional radiology, and it's called consolidation therapy. And so what we do, we would take a little tiny catheter, which is a tube about this long, and would navigate with X-ray guidance under this, through the vessels into the vessel that feeds the liver, and would either inject tiny radioactive particles called yttrium-90, which is the radioactive isotope which emits beta radiation, beyond the scope of this discussion, of course. But what those particles do, they spread through the liver with the blood flow. In other words, they're carried with the blood, just like little duckies think about on the river, and they will get stuck in the tumors. And the radioactive particles will irradiate those tumors. The tumors turn out to be extremely radiosensitive. So, in other words, they will be destroyed by either immediate reaction with radiation when the free radicals are formed, or by delayed reaction. So those tumor cells that are not immediately killed, they will die within 3 months, because the tumors, the problem with the tumors, of course, the cells become immortal, right? They keep on dividing and dividing and dividing. We convert them back into mortal cells by damaging them to the point where they no longer divide. So they will live about 20 days and they'll just die off. So it's an extremely effective therapy. It's now NCCN1 guideline gobbledygook, but essentially the National Cancer Institute says this is what you're supposed to do. Do systemic chemo, follow with internal radiation by interventional radiology, and then put the patients back on systemic chemo at a very, very low dose called maintenance therapy. And that increases, it has been shown to increase the lifespan with metastatic disease by dramatically. And it all depends on cancer, by how much it is increased. But with colon cancer, there are several studies that have shown, multifocal studies done in Europe. In Europe they have much better databases where you can use to study things than in the US. So that's one modality to treat cancers. There are other cancers which we could treat with ablation. For example, if somebody has a kidney cancer, what do you do with it? There are 3 things you can do. A urologist can take the kidney out. In many cases, it's a really large operation, and many people need both of their kidneys. Over time, the kidney function decreases, and so if a young person can give a kidney to his or her brother, An older person cannot do that because there is no reserve left. And so if you take that kidney out, suddenly the person, is at the risk of going on hemodialysis. People live about 2 years on hemodialysis, so it's a very dismal statistic. So you want to keep all your nephrons. So if it's a choice between getting rid of the kidney, or doing something else, many people will choose doing something else. So at Columbia and at Hudson Valley, our urologists are able to take the part of the kidney. It's also a big operation called a partial nephrectomy. And in many cases, they can't tell for sure whether the kidney has to go completely or whether part of the kidney will remain. And so there are other modalities. Turns out that up to 3 centimeters in diameter, about size of a quarter. If the tumor is either frozen or cooked, the result is exactly the same as a surgical resection. So now urologists are referring smaller tumors to us, to interventional radiology, to take a needle, which looks like a knitting needle, about this long, and you, under guidance of a CAT scanner, get it right into the tumor, and you, in many cases, we either cook it, with a very high temperature, or we cool it, and we call it a lethal ice, and it destroys the tumor. It looks like you had a question. No? Okay, very good. Right. So we're able to do the same things we're able to do the same things in the liver as well. We're able to do the same things in the bone. Let's say there is a metastatic tumor to the bone. We can do that as well. We're able to do that in the ribs. We're able to do it in the lungs, although in the lungs there is a bit of a caveat. Depending if you're trying to go for a cure, we would not recommend it, but if somebody is very, very elderly or have many comorbidities, in other words, not a great surgical candidate, we could certainly ablate the lung tumor. And we're finding recently that if you ablate these tumors, that there are little things released from the dead tumor. They're called cytokines. They will potentiate the immune system, and if there are tumors anywhere else in the body, they'll be the immune system is primed, and it's going to start looking for those tumors in other places. So you ablate one tumor, suddenly the tumor in the leg shrinks. If somebody has a sarcoma, now if you've seen those, are called abscopal effects. So that's been studied very actively, but we've seen that the abscopal effects happening everywhere. Other metastatic tumors that we treat, melanoma is obviously a pretty bad cancer, and if somebody has ocular melanoma, the lifespan, metastasizes exclusively to the liver, and lifespan is very low. But even for superficial spreading melanomas, they're difficult tumors to treat, but they happen to be very radiosensitive. So using the external radiation Y90, we can treat them. Now, going from this morbid topic to much less morbid topic, there are lifestyle things that happen to patients to people in the community. And so, if we talk about men of certain age, and I'm getting there, hopefully not too fast, but many people will develop enlarged prostate. Now, there are prostate cancers. We know all about it. You have to check your PSA and maintain the prostate health. But there are these things they call the benign prostatic hypertrophy, and when a prostate grows, which it grows in every male, but only about 50% of people will over time have symptoms. And what are the symptoms? It's either difficulty starting the urination, or incomplete emptying, or slow stream, or having to go to the bathroom in the middle of the night every 2 hours, or not being able to hold the urine for a long time. If someone thinks to themselves, well, can I get on a bus and if I have to pee, can I get on a bus and stay on the bus for 2 hours and come out and still be able to keep my urine in there? In many cases, an older man will say, no, I can't do that. And the reason for it is that large prostate, is not very compatible with the small space that we have in the pelvis. Pelvis, if you think about it, is a box. It's made out of bones, right? 2 bones, 2 iliac bones, one on the back called sacral bone, and on the front there is bladder. So if something starts growing inside that pelvis, there is not a lot of room for that thing to grow. So when the prostate starts growing, it starts stealing space from the bladder. So the bladder doesn't have as much capacity anymore. It cannot store the urine. There was an article this summer in the New York Insider. It said, it's right here on my screen. It's funny. But it said rich New Yorkers are getting surgery because they get stuck on a LAE trying to go to to the Hamptons. So they can't stay in their car for 3 hours. So it turns out they get this procedure called a prostate artery embolization. So it's very, very similar to what we do for malignant tumors. Prostate is made out of cells. Cells needs nutrients and they need oxygen, right? Every single cell in the body. Let's say nutrients and oxygen are taken away from the heart. Let's say there is a blockage in the heart. Person could end up with a heart attack. Obviously ischemia, lots of chest pain, and the cardiac wall will die. Well, the same happens with the prostate. So if we block off somehow the blood flow to the prostate, you will definitely not going to have a heart attack, but that prostate will shrink. It will shrink and shrink and shrink to the point where the central, the prostatic urethra, or the central portion of the prostate, will open up just because that the prostate is losing volume. And suddenly, a month after, a person who could not tolerate that drive to the Hamptons, able to tolerate the drive to the Hamptons, suddenly the urine stream is back to normal. Suddenly they're able to sleep through the night. All the procedures that urologists used to do, they used to do also, they still do that. And, I'm not knocking my friends, the urologists, because those are the folks who send me those cases. But they are not able to deal with very large prostates. So there is a limit to what they can do. Normal prostate is about 20 grams, small size. Many men will grow prostates to 140, 180, 250 grams. So it's a, essentially monster prostate. So when a prostate is small, and there are some symptoms, urologists can offer things. They can offer something called the green laser. They can offer something called the Urolift to prostate up to 60 grams. They can, even for larger prostates, they can offer a procedure called TURP. So essentially, and if part of my graphic description, they'll take this metal thing, which is a rotarouter, and they'll go down the urethra through the penis, and they'll just rotarouter the prostatic urethra, just like you would rotarouter your sink. Now, of course, it's done in general anesthesia. The patient is asleep, but when they wake up, they have this really large tube sticking out of them. They're in the hospital for a couple of days. Oh. My grandfather had one of those. I remember him kind of sitting in a gown with a giant thing. He was so miserable. I remember that. So not great. But it's also limited to the size of the prostate. Certain people, if the prostate is above 80 grams, they can't get that procedure done either. So they're limited to three things. They either need to get a prostatectomy. So the surgeon would come in with a knife and just take their prostate out. That obviously leads to incontinence, retrograde ejaculation, impotence, very bad things. But sometimes that's what's necessary, because the two other options that urologists offer is a catheter from the penis to the bag for the rest of their life, or the tube below the belly button for the rest of their life. So those are the options. Now, recently, a couple of years ago, interventional radiologists essentially came in and we said, we'll block off the prostatic arteries and see what happens. And we're able to block off the prostatic arteries. Procedure takes about 3 hours, and lo and behold, prostate goes back to almost normal size, and people are able to go to the Hamptons, no problems. So we're doing these procedures and at Hudson Valley. We used to do them only at Columbia, but we upgraded, thank you, Dan, for releasing about $300,000 to upgrade our machines. But the machines are able, it's a very specialized procedure. You cannot do it in a doctor's office, done at the hospital. But the machines are able to tolerate our requirements. Now, the same thing happens with women. Less of an issue with women of post-menopausal age, but still an issue. Fibroids, very analogous to the prostate. Uterus is a small organ. It's there for gestation for the baby to grow in. But over time, women are predisposed, and genetically some are more, others are less, to grow in these benign, non-malignant, non-cancerous tumors inside the uterus. They're called fibroids. Mm-hmm. They take up the entire pelvis, and in premenopausal women, it causes lots and lots of bleeding during the menstruation, but it also causes bulk effects, just like in men with prostate. So women will have lots of heaviness, the belly will get bigger, they're not able to sleep through the night, they have to wake up to urinate, or they will restrict, how much fluid they take before going to bed, because they try to minimize waking up at night. During the day, they have something called urgent continence. In other words, if you have to pee, they have this urge, and you have to find that bathroom like right away. When they were younger, they could hold that urine, get on that, Hampton's jitney, and have no problem. But with age, when the fibroids get larger, they end up in the same problem. Pelvis is the bunny box. There is only so much room in it, and the fibroids start occupying that pelvis, less room for the bladder. So we are doing these procedures, and this procedure has been around for a very long time, 30 years, called uterine fibroid embolization. Was discovered accidentally when, during pelvic fracture, or for treatment for pelvic fractures. Sometimes we would have to block off the vessels going to the pelvis if the pelvis was bleeding, and people had fibroids. When they recovered from the pelvic fracture, suddenly their fibroid symptoms would go away. So people looked into it a little bit more carefully and found out that if you block off the uterine arteries, the vessels that go into the uterus, the fibroids will shrink and go away, and the uterus is restored to normal size. Now, GYNs offer procedures for that, right? You can do a myomectomy, take the fibroids out surgically, or you can do a hysterectomy, which is a pretty serious procedure, which causes many things that are not advertised. The uterus sits on these round ligaments. It's like a suspension bridge, and it holds up the pelvic floor. If you get rid of the uterus, you get rid of the ligaments. It's like cutting the suspension cables in a, cutting the suspension cables in a bridge. What happens to the roadway? Roadway sags. Same thing happens with the pelvic floor. Vaginal prolapse, rectal prolapse, all sorts of unpleasant things. So hysterectomy, in addition to being a major surgery, is not something that people should consider unless there is cancer. Because there are, minimally invasive technique like uterine fibroid embolization, which is very, very easy. 2-hour procedures, been done for 30 years. Condoleezza Rice had that. So we do those on the outpatient basis. So there are many, many other things that I can talk about, but I know I'm limited for time, so I'll stop here.
Okay.
Oh, one more thing. The summer is coming. Everybody wants to have beautiful-looking legs. Nobody likes varicosities. We can treat varicosities very well. One quick thing. Over time, there are, the vein that drains the leg, called the greater saphenous vein. Over time, there are valves in that vein that when you stand up, the blood goes up, obviously. The blood has to come back to the heart, right? The heart pumps it out, but somehow it has to come back, happens to come back through the veins. But the veins, when you push the blood through the veins, it's done by passive transport. In other words, you move around, and the blood is being pushed by your leg muscle. That's why when you're on the airplane, you gotta get up and walk around every half an hour. Otherwise, you could develop a clot, right? Same idea. You don't want stagnant blood. So when you stand up, that column of blood is not supposed to go back down. So there are little valves. It's like little locks in a Panama Canal. They open in one direction, going toward the heart. When the blood wants to, by gravity, Sir Isaac Newton, go back down, the valves will close, and that will prevent the column of blood from going down. Over time, especially in women, and it has to do with pregnancy, a lot of things. My wife tells me, "Oh, if I was not pregnant before, these things would not have happened." In any case, but often related to pregnancy, but also related to genetics and sometimes related to age, there are little leaks that develop right where the valves close, and so there is a little tiny hole, and so the blood starts leaking down. And where does it accumulate? It accumulates in the legs and becomes. There are capacitant vessels in the legs, which our body is an ingenious machine, and it will absorb that extra blood, but it will, those absorbent, those extra channels are the varicosities. So people have these ugly varicose blue veins. People know what they look like. And so, believe it or not, it's an easy 45 minutes procedure to fix those. We use a laser, and we would destroy the entire greater saphenous vein, which is a superficial vein. You don't need it. And then the body will take that blood that is draining the skin and will divert it to the deep venous system. We have 2 venous systems in the leg: deep venous system, femoral veins, and a superficial veins. The superficial veins, like I said, they're redundant, but they're the ones that run into problems. And so once you destroy the superficial vein with a laser, all the blood goes into the deep venous system, which is much more robust. The valves are much more robust. And suddenly, the person has no varicosities. And if you delay the treating one leg versus the other, one leg is beautiful, the other leg has varicosities. So we try not to do these procedures, during the summer, because we have a lot of delinquency. I don't want to call it delinquency, but we ask people to wear, compression stocking for about a week after the procedure to allow the vein walls to kind of collapse. And in the summer, it's so hot, people kind of sneak that thing off, and you end up with some failures. So we try to do these procedures when it's cold. You can wear pants because there is a bruise for about 3 months. Nobody wants to show off the bruise at the pool. So now is the prime time to do those procedures. It's a lifestyle, but in many cases, it's not really a lifestyle. There is skin discoloration. There are non-healing venous ulcers. The swollen legs at the end of the day. These are all of the sequelae of those valves, which are easy to fix. And now I'm going to stop. Right? Do you have any questions?
Is that procedure covered by your medical?
Great question. So if you come to us and you say, I just don't like how my leg looks, no. But if you really, most patients will, in addition to the varicosities, they will have a little bit of swollen legs at the end of the day, leg heaviness. Some will have, hair loss.
Right.
Some will have even, ulcers that don't heal very well. So in that case, it's called medically necessary because it's a lifestyle limiting and insurance pays for it. As long as you have a little bit of swollen legs. And most people with this issue will have the swollen legs just because it's a physiology of the disease.
Thank you.
Yep. Yes, ma'am.
You mentioned the word ablation. The only time and obviously I'm not a medical person.
Yes.
The only time I've ever heard of an ablation is with regard to the heart.
Right. So in the heart, there are ablatable areas. If somebody has, for example, atrial fibrillation,
Right.
abnormally beating heart, there are areas where that signal originates. So there is a normal area which is called SA node, which is in the atrium. That starts the heartbeat. Then there is another area where if the SA node fails, it beats slower. It's in a ventricle, and it's called AV node. And that area also is associated with normal but slower beat. But there are these ectopic, they call them ectopic points, where the beat is started by those irritable cells, but at random points. And so your heart rate becomes irregular. And why is it bad? Because it's like taking the blood, putting it in a bag and starting shaking it. What happens, you start developing clots. And where are those clots going? Going to the brain, going to the kidney, going all the way down to the pinky toe, right? So for that reason, the special type of cardiologist called electrophysiologist, and they have those at Hudson Valley, will come in with a catheter that will map out, where are the abnormal firing nodes are, and they will ablate those. Ablation is a generic word, meaning you heat it and just to destroy it, or you cool it to destroy
Good.
it.
Okay.
So that's a very similar concept, different organ.
Does anybody else have any questions? Go ahead.
Go ahead.
Could you just touch on heart health and maybe how radiology can help show us any blockages or things like that? Maybe be proactive with our heart health?
Sure. Well, you should probably talk to a cardiologist because they are the subject matter. I can talk to you in generalities. So radiology can, there are many different scans that radiology does. And, we can do nuclear stress tests. And that it's a study to see whether when a heart is loaded with stress, whether any areas of the heart start failing. And that is usually indicative of a vessel going to that area of the heart that is failing. And then you'll be referred to interventional cardiologist who would go into the vessel and take a look at it and potentially put a stent or balloon into it. There are cardiac MRIs where you can look at the heart motion at the vessels. There are cardiac CTs where you can do the calcium scoring. So in other words, they're looking to see, how much of the calcified plaque are in the heart vessels. Most people with blockages in the heart will have absolutely no symptoms, right? But those blockages in the heart or in the legs, speaking of the legs, there is enough blood in many cases for the organ to, for the heart or for the leg, for example, to not send you any signals, at rest. But if you load it up, you need more demand. Your muscles are saying, hey, more blood is needed because I'm burning sugars, so more blood is needed. And if, let's say you have a blood flow of 5 liters per minute at rest, when you're sitting, if you start running, you need 15. Now, if you have a blockage in the vessel that's going to the leg called femoral artery, it's called a fixed defect. right? Normal blood vessels will dilate and they will deliver that 15 liters, but if you have a fixed defect, it's like you take a, you take a piece of furniture and block half of this door. No matter how wide the door is open, if it's blocked with furniture, only so much blood can get through. So those fixed defects, when you load up the heart or load up the leg, they'll show themselves in the heart with a chest pain, and in the leg with something called claudication. You walk 2 blocks and you have to stop, and like you walk another 2 blocks and you have to stop because it's painful, right? It's a reproducible issue. So, the radiology, general radiology, using cross-sectional imaging, CAT scan, for example, can evaluate, the amount of calcium in those vessels and can tell you whether there is a very risky, very high-grade calcified plaque in there that's just sitting there for you to run up the flight of stairs and you'll have a heart attack. So you can, that's very helpful. But about cardiology issues, the best people who talk to? Cardiologists.
Cardiologist.
Yeah.
Anybody else have a question? No more questions?
All right,
Wonderful.
wonderful.
Good. Thank you so much, doctor. Thank you. Thank you. Thank you. Okay, Noreen, does anything you want to say?
Yeah.
What's her paper back? There you go. Sorry. You know, Noreen is our Director of Senior Services. Takes a lot of people to deliver these services.
Hi, good afternoon. My name is Noreen O'Driscoll, and I'm the director of the Yorktown Senior Center. Healthy aging is crucial to helping seniors remain independent and helping seniors to remain at home. So our town offers a resource that can help do that, and that is our Senior Center. Our program offers a nutritious meal planned by a registered dietitian. Meals are provided on-site or at home for the medically eligible homebound seniors over 60 years of age. Meals are provided Monday through Friday for a suggested $3 per meal. I can't stress enough that our seniors, our services are so much more than just a meal. For our seniors that receive our homebound meals, it's that friendly face every day saying, hey, how are you doing? Is everything okay? Do you need anything? And then that driver makes a connection with the senior in the event of a change. So if they're going to that home every day and they're seeing the senior every day and they're saying, whoa, something's not right, Mrs. Jones wasn't talking the way she was yesterday, they bring that back to us at the center, and then we'll notify the family. And 9 times out of 10, we're not right. But when we hit that one, that we can help that person that has something going on that the family might know about, that's a very important part of our program. It's also a checkup with a social worker once a year that calls you to see what kind of needs you may have. A registered dietitian contacting you to see your dietary needs, to see if our program is meeting your needs. And then we have our senior center, located at the Albert Cappellini Community Center on Commerce Street. It's a place to come with your friends or to come and make new friends. We are a very welcoming group. And we actually had 6 new people start over the past couple of weeks, which is very, very big. Nice. New people in the community that are just looking to get out and make friends. We have various social events and parties that any registered participant is welcome to join in. We laugh, we sing, we dance, we have fun. Just recently, we decided that our theme song at the center is We Are Family.
Would you like to sing some of it?
I won't sing. I'll spare you that. Linda and Ann here can say, you don't want that. Ann can tell us that too. But because we say that because we do share our good times and our bad times, and it just is a family. Once you join, and we are very, very welcoming. So please, anybody out there that wants to get out of the house, I can't stress enough, please come in. Very, very friendly people, welcoming people. And then we offer various educational speakers. So if you check the senior newsletter coming in March, we have the chief of police coming to speak in March regarding senior fraud. We have a dietitian from the Westchester County Department of Senior Programs and Services coming. We always work with our town supervisor and our town clerk, Diana Quast. For any need that a senior may have, I can contact them. They are over in minutes if you need help with anything. We're a liaison to the senior services that you may need from the Department of the Aging. We provide any senior that lives in Yorktown transportation to our center. And a new program we offered is our telehealth program. It's offered on Mondays from 9 to 11. It's located at the Nutrition Center. You come in, your vital signs such as your pulse, weight, oxygen level, and blood pressure are measured. The data is then transferred to the telehealth nurse who will review it remotely. And if the test results show cause for concern, we'll contact the senior or a caregiver to let them know that something's not right and you should get checked. So that's a quick description about our services, and I encourage any senior who's here or who's watching us to call us for more information. If I can't answer your question, I always try and direct you to someone who may be able to help you. And our number is 914-962-7447. So thank you for your time.
Could you
Thank
repeat
the number?
when you do this?
The telehealth
Yeah,
program?
telehealth.
The telehealth program is on Mondays from 9 to 11. At the Albert Community
Yeah, the community center.
Yes.
You started talking about eligible seniors. What exactly are the things needed to become an eligible senior? Can you repeat the question so they can hear on TV?
Eligible for the meals at home?
Yeah, meals at home, anywhere they come to your location.
So the only eligibility rule to come to our location is that you have to be a senior over 60 and be able to take care of yourself or have an aide with you. If you're not physically able to do that, then you have to have an aide. We don't have the Meals on Wheels program. Yes, it is, Jim. Good question. That is a medically necessitated program. You have to have medical reasons to have that.
Is it a doctor's note specifically?
A doctor's note. So what would happen was we take an application over the phone, and then we get your ailments and then we determine whether that coupled with, then we send a note to the doctor to send back to us.
Anyone can call you and
That's correct.
walk them through that process.
That's correct. Yes.
I know.
Hi.
Thanks for all you do.
Thank you.
Is there a weekly charge for Meals on Wheels, or if you are eligible, is that free of charge?
So there is a $3 suggested contribution. Nobody is ever turned away for lack of funds. It's completely confidential, and nobody's ever turned away for that reason.
That's wonderful, because in other towns, they do have to pay, not a lot, but they do have to pay, so the fact that that's a suggested donation is really a wonderful part of your program.
Yes, it is. We are funded from the federal to the state to the county to us.
And a lot
To
of
the
people
towns.
don't know about that. And I encourage everyone, you know your neighborhood. If there you have not just a senior, but an elderly person who lives alone, maybe you would want to check in on them from time to time, especially if you have a relationship with a neighbor, because they don't know. There are things that they do not know about what's available.
That's
and
right.
you do a wonderful job, and
Thank
your
you,
group there is incredible. And someone may have an accident. Someone perhaps can't drive for a period of time or has been hospitalized. They can have this service, and it's a wonderful thing. A lot of people do live alone and are unaware of this situation. So we try. That's why we try to get it out there so people know what's available to them. Good, very good.
Thank you. Thank you.
Thank you. Next, we're going to ask Jim Moderano to get up and say a few words. Also does a wonderful job. Director of Recreation, yes.
Thank you, Rosemary. Thanks for having me. Just a couple things to talk to everyone about. Actually, I want to start with the best news. We've been working with the Chamber of Commerce recently on providing some senior information, not only within the town government, but also within the businesses within the town as well. So we're going to be working diligently with the Chamber of Commerce on some sort of pamphlet and page and online resource for all the seniors in our community. So that's very exciting news. Probably more news on that to come. Sammy, can I hold you to this on March 15th? That's happening. At the JV Mall, the Chamber of Commerce is starting a new program on the third Wednesday of the month. So March 15th is going to be the first one. Senior speaker series. That's going to be 10:30 to 12 o'clock at the JV Mall. Warm meal with coffee. And some non-perishable groceries as well will be on location. So mark that, save the date, March 15th, and we'll have more information on that.
Tell us the time again.
It's going to be 10:30 a.m. to 12 noon.
Okay.
Yep. March
Okay.
15th. Yep.
Very good.
At the JV Mall. So when you walk in the JV Mall, you'll make a left, and you'll walk straight down, and you won't be able to miss it towards the end there. So that's very exciting. We're happy about that partnership. Another thing that y'all should know about is we have the Yorktown seniors that meet on Tuesdays at 10 o'clock. They'll be offering free breakfast on the first two mornings in March. So first two Tuesdays in March at 10 o'clock, free pastries. Just to get to know that group. They're looking for more membership, so they'll be having free pastries for anyone that's looking to join and potentially signing up for that group.
Tell us the group again.
Yorktown Seniors on Tuesdays at 10 o'clock. First two Tuesdays in March, they'll be having free pastries for any senior that's interested. That's at the, thank you, great question. That will be located at the YCC, room 16. So when you walk in near the stage, you'll make a left, and they'll be slightly to your left, room 16 at the YCC downstairs.
Wonderful.
So, and we also have a number of senior trips coming up with the Shrub Oak seniors, as well as the AARP group. So look out for our senior flyer that we'll be putting out at the beginning of March. That's online, and there'll be hard copies here at Town Hall to peruse as well. So there's a lot of fun trips going in this summer and into the fall.
And will this information that you gave us this morning be in that newsletter?
In the senior newsletter that we post bi-monthly, yes, it will
good.
be all
Thank
in
you.
there. Yep. And you can get those at Town Hall, at the rec office, or online under yorktownny.org/Parks and Recreation. Question? Yep, Yorktown Senior Group. They're going to be meeting the first two Tuesdays of March at 10 a.m. The program starts, and they'll have free pastries at those events. And there'll be bingo to follow, so bring your pennies.
Thank you.
And that's all I have for now.
Thank you, Jim.
We're going to have
Thank
our
you.
general brochure that's going to be coming out for a lot of our senior fitness programs for spring and summer, and that should be coming out in mid to late March as well. So look out for in your mailboxes for that bigger brochure with all of our programs that are going to be going on in spring and summer. Yes.
Jim, it has nothing to do with what you just said, but a couple of times, a couple of seniors have expressed a concern about when you go down to Care Street, about a bench being put there. Are you were going to take care of that, or Dave Paganelli?
Yeah.
There was one there, it was taken away, and
Yep.
they want to know if it could be put back.
That's definitely a conversation I need to have with Dave because that is not on park property.
Okay.
What I can do is just necessarily stuck with the park property, but I can certainly help Dave with that.
Okay. Could you mention it to Dave for us?
yeah.
Because they've requested it a few
And
times.
I think the ownership of that road specifically was in question. So, is it the person that owns that property is the one that should be putting that in, or should the town be putting that in?
Yeah,
So
I
there
know,
was
I know
some
there was
gray
some
area
questions about it, but I'm leaving it up to
there.
you and Dave.
Yes, and Ed might be able to help a little bit
Probably a
with
liability
that as
problem.
well. So.
Yeah, show me later which corner it's supposed to be at, or where exactly where.
I believe it's coming off Beaver Ridge over here.
Yeah.
As they come across there by that sign where it says all the businesses.
That's the Kmart property.
Yes, that's what I thought, and that's what got us crossed up in the past when speaking about it.
Okay. We could always ask our supervisor to call Oster.
That'd be great. Yeah.
Okay, so you'll take care of that, Ed? You'll ask the supervisor? Thank you.
Yes, ma'am.
But yes, I mean, a lot of people commute from there, coming from Beaver Ridge, and that's a big crossing spot for people in that community. Any other
Oh,
questions?
yeah, I know, I'm going to ask them.
All right, well, thank you all for having
Thank
me.
you so much. Thank you so much. Thank you. Councilman, did you want to say anything?
Please. Have a good day, Rob. Good evening, all, or afternoon, all. Feels like evening with this weather today. I have something, but I wanted to piggyback on something Noreen said because I was helping with the Meals on Wheels during COVID when they had shortages, and it really is a home check as well, more than just to see how someone's responding. There have been quite a few times that there have been people in distress that have not been able to answer the door that we've been able to get paramedics over to and get some help for them. So it is a really great program on many, many different facets. And I'll also give a shout out to the Chamber. I am on the board of the Chamber also, and we had a conversation about food insecurity and the need for the seniors. So I don't know if you realize when Jim had said there would be non-perishable foods there, that's sort of to supplement what some people may be using a food bank for, to try to really help assist our seniors as we know fixed incomes are being squeezed and squeezed and squeezed. That brings me to my news. I know I have Mr. Safone, who's very good at coming in for things to talk about. Please watch the calendar for the town board meetings. We are going to refer out a law this coming Tuesday, and then there'll be a public hearing on it. And it is basically to raise the exemption rate for the town taxes. Unfortunately, the schools have not gotten on board with it. But that will right now you're allowed to claim $37,400. That will raise it up to $58,000. Right. So it's a really big effect to our seniors to give you almost a full what is that $11,600 that will help you out there, that you could declare and not have to pay taxes on. In addition, I have asked to be added into that another part of the law, an adjustment to income earned by veterans on a pension from their service. So if you were a veteran that was injured and you receive a pension, that right now is included as income. And I'd like to see that removed as an income inclusion, and that is something that the town can exempt. So we need our veterans, we need our seniors to come and talk about that.
Wonderful.
And
That's wonderful.
really,
That's going to be the February 21st meeting, right? February 21st. This is
Well,
going to air for next month, so I want
yes. Well, we're referring out at the February 21st meeting, so that'll be a 2-week referral. So we should be probably March 7th. Yeah, the 7th should work, providing everything's back. So we should be looking at the public hearing on the 7th, but please watch the website and come up on that. It's a big thing, and I think it's a really, really important aspect, as everyone on the board does right now, especially with what's happening with our economy. And, I was thrilled to pay commercially $2.70 for a dozen eggs yesterday, buying a case of 15 dozen, where it used to cost me 96 cents when we do the fundraiser at the American Legion Hall, which is this Sunday, 9 to 11.
All right.
The veterans breakfast we do it the third Sunday of every month, and it's a $10 donation, and it's not just pancakes. It's pancakes, eggs, corned beef hash, bacon, sausage. This month we'll do sausage gravy and biscuits as well. So there's a lot going on there.
I just have a question, and I don't know if I heard the right information. I heard that Lakeland has approved an exemption, but for the school, but Yorktown has not. Is that true?
I
or is
have
that
not heard that any of the schools have approved it as of yet. From my understanding is they want to see, so it's a pretty wide target right now to how much effect it's going to have on everyone.
Yeah.
And the schools want to see how it affects the town. and then I guess make their decision from the percentage that it changes.
That's why I wasn't sure whether it was a rumor or was for a
Yeah,
fact.
I would say nothing is there until it's signed.
Okay.
So the exemption will be on the school tax?
No.
No.
The
Okay.
exemption right now is on the town tax.
Okay.
And we're hoping the schools will piggyback on.
Okay.
But that probably will be a year down the line.
Right.
Okay.
Okay.
Very good. Thank you,
Thank you all.
Councilman. Thank you. Thank you.
Thank you for the good news.
I just want to remind everyone that next month, March, the third Friday falls on St. Patrick's Day. So we have decided to move the senior advisory meeting till the following Friday. So that will be the 24th. So I just wanted to let you all know that right now, and we'll put it up on the screen as well. Okay? Okay, is there anything else? Did I leave anything out?
No.
Okay.
I think we covered everything.
Okay, so we look forward to seeing you next month. And thank you to all of you for all of your hard work. Thank you all. And we'll see you then. Stay well, be healthy.
Guess not.
Have a happy St. Patrick's.
Did the chamber want to talk or no? Did you want to see? No.
No, because they have to let me know.